So, welcome everybody. This is a Friday afternoon treat. We've got a fantastic panel of experts today to give us advice on some very timely issues. Firstly, I'd like to acknowledge the traditional owners of the land, of elders past and present, on which we all collectively stand. I understand that we've all dialing in from very geographically diverse areas. Just a bit of housekeeping to begin with. If you could all please mute yourselves unless you're speaking. If you have questions, we're going to leave the questions till the end, but if you do have questions, please put them on the chat function or send them privately to New South Wales RACS. Should we not have the chance to go through all of your questions, we will send them, email them to our panelists, and we should be able to email them back to you. So don't feel that your questions will not be answered. And also that we will be recording this session. So for those of you who may have to jump off because you're operating or other commitments, this will be available later on. And also if you have colleagues who would be interested in hearing, please let them know that this will be available to them as well. So without further ado, I'd just like to introduce our panelists. Firstly, we have Dr. Kate Cleese, who's an infectious diseases advisor for the Clinical Excellence Commission. She has worked for South Eastern Sydney Local Health District for many years, and most recently as Head of Department for Infectious Diseases. Kathy Dempsey is an experienced infection prevention and control practitioner and a senior manager of the Healthcare Associated Infection Program of the Clinical Excellence Commission. Melissa Coward is a membership manager at ASONS, the Australian Society of Head and Neck Surgery and Otolaryngology. She provides support to members and at the federal and state level, as well as individual members. Terry Gorman is the Senior Occupational Hygienist in the Personal Safety Division of 3M. He has worked with 3M for over 20 years, and in this role he's been testing, trialling and recommending a wide range of PPEs. We're still waiting for one of our panellists who's running late in theatre, as many of you will understand, Professor Arthur Richardson, who's the current Head of Upper GI and Hepatobiliary Surgery at Westmead Hospital. He's been one of my predecessors as a previous RAC State Committee Chair, but he's currently here in his position as the Chair of the Surgical Services Task Force of the ACI, which is currently also the Surgical Community of Practice. Last but not least, I'd like to introduce our first speaker, Dr. Amanda Cuss, who is a Senior Medical Advisor for the Device Section of the Health Products and Regulation Group of the TGA. She's been in this role since 2017, and she's commences after her surgical training. Amanda is a surgical trainee who's currently also a GP, and she practices as a doctor as well as an advisor for the TGA. During COVID-19 pandemic, Amanda's been assisting with point-of-care testing and ventilator reviews, as well as PPEs. So I am really excited to introduce Amanda and listen to her talk. Amanda's got a few slides. We'll move on to Terry's talk, but just as whilst Terry is switching over to his slides, I suppose what I was wondering, a question for you, is that right now with increased medical mask use, for example, in Victoria, the reason for the use of the mask in the public or face covering, or globally in fact, is to prevent transmission between people. And you know, they're allowed to wear a face covering or cloth mask. Where does TGA and those indications come in?
So that then is more about the decision process of the consumer, the user itself. So by all means, anyone can walk into Bunnings and buy a mask and use that as a barrier. But what it means is if it's a mask that is not intended to prevent the transmission of infection, you may still use that as a barrier if you're a consumer, but you couldn't possibly then, if you then got coronavirus whilst you're wearing the mask, you couldn't go back to that manufacturer and sponsor and say your mask didn't work, because that was not the intended purpose. So in terms of end user, they can still, realistically, you can use whatever you want, except for those of us who are clinicians where we're in the surgical or clinical situation. But anyone can use whatever they like, including those cloth masks, because it's a barrier. And it is, you are correct, it is still kind of in terms of transmission, but that's their decision. And it's more about that they are therefore taking the risk that this product has not been assessed by the TGA for a particular intended purpose to prevent transmission of disease. So it's all about, so there's that level of who's supplying it and what they're saying it's used for, and then the consumer ongoing from there as to what they choose to use it for within limits.
Thank you so much. I can see that Terry's ready for his slides. We'll come back later with you to you with questions. Terry, please get started.
Thank you, Payal. Just a quick intro. As I said, a certified occupational hygienist. I'm a member of the Australian Standards Committee for Respiratory Protection, and also on the ISO committee, which is writing an ISO standard for respiratory protection. 3M makes me put in a disclaimer, so any information I give should be taken on board and checked for application in your specific areas. So you don't have to read that. That's more general statements there. So being a hygienist, it's incumbent on me to push the hierarchy of controls. The PPE, as you likely all know, is at the bottom of the list of controls, because it involves people, and that involves complications and extra steps. I'm getting... So human interaction and PPE effectiveness are tied together. It's got to be done properly to get protection. Must fit the individual. If we're talking about a fitting type respirator, it must be worn every time it's needed, and it must be worn properly. So there's a whole process of using product to make sure you're getting the protection that you expect, or the worker is. In terms of particles, Aerosol Science has been working on this for years, and it's well known that particles will hang in the air. It's well known to hygienists. We worry about people who are, depending on the conditions, several metres away from a source. So you can see 20 micron particles will hang in still air for over 3 minutes. Something as small as 1 micron size particle can hang around for 12 hours. So there's considerable scope for exposure to a small particle in a space over time. And I think that's where some of the current discussion about droplet transmission, airborne transmission, etc., in regards to COVID-19. This is obviously a concern in terms of the potential for transmission at distance, as opposed to the old 1 metre rule that has been used in the past. So the airborne hazard could be continue to be present long after work has stopped. Even people have left the room, come back in again. The other issue that I keep running into is it's becoming better, but people have been and perhaps still are a little bit confused about face coverings, surgical masks or masks versus a rated P2 or N95 respirator. So the face coverings or a surgical mask are more of a barrier, as Dr. Cuss said. They're there to protect against a large droplet type exposure, where the mask acts as a physical barrier and can reduce that sort of exposure. A respirator is being used as a filtration device, so it is designed to fit the face, and thereby the air coming through the mask is filtered, and you are getting a reduced potential or real exposure to a droplet or a fine particulate. So it is giving you a level of protection, a rated level of protection under the standard that it's used. A half mask like a P2 or an N95 under the Australian standard, and indeed most standards, is rated to give a minimum 10 times reduction to the concentration of the contaminant in the outside air. It's obviously you need to find the appropriate level of protection for your situation, but a half mask is used in many workplaces and besides healthcare to give a level of protection against airborne particulates. Anything that's tight fitting needs to fit the individual. It's like shoes. You can't just whack on any old pair of shoes. You need to find a product that fits your face as opposed to mine. Fit testing is a process to do that, to determine the efficiency of the fit on your face with product X or product Y. It needs to achieve an appropriate fit so that you know you will be getting a level of protection. The fit test identifies the type of product or the size or the model that fits your face. Comfort is often overlooked, but it's an important part of the process. The product might fit you, but if it hurts, it's going to cause issues down the track. And the other issue also is compatibility. If you're wearing a mask, if you're also wearing eyewear, if you're also wearing other types of equipment, that should be taken into account as part of that fit test. I was asked to talk briefly about PAPRs. Powered Air Purifying Respirators is the full name. They'll be called PAPRs or PAPRs. This is where contaminated air is drawn through an air filter unit, typically worn on the waist, and then clean air goes through a filter, and then the clean air is delivered up to a head top. This sort of unit provides higher level of protection than a half mask, like the N95s or P2s. It can offer multiple layers of protection, so it's not only respiratory, it can provide protection to the head. Perhaps that's a bit more industrial, but certainly protection to the eyes and the face, so from splash or from exposure. PAPRs are not necessarily on the ARTG. There are, I believe, a few, but not a lot. But again, it's a potential for use in that area with the right backup. As Dr. Cuss said, it must be directed at therapeutic use. PAPR's advantages are a number of features. You get a clear face and clear communication. I know people in healthcare are concerned about the impact of a mask on a patient. If you're trying to communicate with a patient, you're much less threatening if they can see your face. Communication is clearer without the masking effect where the sound can be interrupted. So it helps from both directions. You have continuous airflow, no breathing resistance, so there's no effort to breathe. It's breathing as normal. That promotes comfort. No fit testing is required for a PAPR with a loose fitting head top. So as shown in those pictures, hoods or head coverings, there's no fit testing required. They can deal with a certain amount of facial hair, so that is of great advantage to people who love their mustaches, their beards or whatever. There is a limit. You can't have Mr. Harley Davidson or ZZ Top, for those of you of that ilk, with the gigantic long beards. That's problematic, but certainly reasonable facial hair can be dealt with a suitable PAPR. Other issues to consider would be the cleaning and disinfection of this product to obviously enable reuse. That's something that is has to be considered in the processes that you are using in your workspaces to determine how you're going to deal with that on an ongoing basis. Also requires maintenance, battery changes, etc., and battery charging. Of course, it's run by a battery that you need some sort of process in place for that. So PAPRs have their advantages. They certainly can give us another option. I was also broadly asked about 3M's position going forward. I can't be too specific about 3M at this time in this pandemic process. We will learn lessons from the pandemic regarding logistics, supply issues, even product or potential product development that will be going on in the light of, you know, all of the demands or the requirements or the requests coming from people in healthcare in all different applications. So too will governments and healthcare organisations from the issues that are arising for all of us in our areas. The question of local manufacture and demand, I can't obviously commit 3M to anything, but you've got to think about there's 300 nations on the planet. They will all be thinking and wanting a factory in their country at this time, I would imagine. So that's an issue for governments and manufacturers going forward again, how we deal with those sort of logistics and supply issues going forwards. Whether that increases the importance of stockpiles, how big they are, all those things will need to be assessed. There's obviously not one answer and a lot of inputs into that. I think that's the last thing I've got to say. Just before I finish, a quick plug for another event, Anaesthesia Approach to Aerosol Generating Procedures, Risks and Advanced Respirator webinar coming up on the 13th of August. Some good speakers there, Ken Loy, Paul Stewart, Mark Reggers, my colleague. So anybody interested should note that. There'll be some information flowing around for that, but that might be another opportunity for you.
Thank you,
and
Terry.
I believe that's done.
Thank you. That was very informative. I just wanted to, just on the back of all of that, in the last week we've had we've had an increase alert. So New South Wales Health has put New South Wales on amber alert for where COVID is. And I just had a question for Kate. Obviously, even just during this conversation, during this webinar, we've seen that there are two issues. As surgeons, we're very used to thinking of PPEs as protection, but the new guidelines are really more centred around one of many strategies to prevent disease spread. So it's risk mitigation. And that's why we're starting to get into this discomfort about, you know, what about the lower grade range of protection? So I just wanted just some comments from Kate initially about if you could just give us your expert input in clarifying how we manage that.
Thanks, Pale, and thanks for, I hope you can hear me.
Yes.
Yep. Thanks for inviting me on the webinar. I guess from a surgical perspective, surgical masks are principally used to protect the patient in terms of reducing surgical site infection. So this is a whole different way of thinking about protection. So surgical masks are not for protecting the surgeon for the most part, except for some splashes and sprays, but it is also for reducing surgical site infections, which is clearly an important process. So this is a real change in the way we think about personal protective equipment. But the other things in terms of risk mitigation are, and these things always exist, are, you know, what are the administrative controls? So obviously things like not too many people in the space at one time, and physical distancing. So we know, based on what Terry said about droplets, the large droplets go about 1.5 meters. And there's an important conversation here as well, and I'm happy to talk about that continuum between aerosols and droplets, because when you breathe out, mostly it's droplets, but there's a continuum of size. There's not just droplets and just aerosols. It's been a convenient distinction in terms of thinking about PPE and what a surgical mask will protect and what a P2N95 respirator will protect you against. And neither of those is completely perfect, but they do offer different kinds of protection. We talked about engineering controls, and there's things like using a room with appropriate numbers of air changes. We think about what Terry said. He said, I think on that slide, the very small particles can last in the air for 41 hours, I think was what it was, something like that. They can last, and maybe it wasn't that long. It was quite some period of time. And so if you have a certain number of air changes in the room that you're in, then that means that after the right number of air changes, then those particles no longer exist. But they're the sort of administrative and engineering controls. And then you come to personal protective equipment, and really the most important things about personal protective equipment are understanding what the risks are. So if it's a splash or a spray or droplets, then a surgical mask and some eye protection are adequate. If they're principally aerosols, say with an aerosol generating procedure, then you'll need to protect your airways from those small particles, which is a P2 or N95 mask. And then or respirator rather. And then there are other parts of that personal protective equipment, which include as you would in the operating theatre situation, include a gown plus gloves. But those things are not, it depends on the clinical setting, but it's about understanding what the risk is and then knowing what PPE to choose for that situation. So I think there are a range of things, and I think if you've been working in infectious disease or infection control for a long time, it's one of those things that we're very familiar with, but I think it's and I think it's really great that the rest of the medical community are now learning better how both to do risk assessments and how to choose and use PPE properly. And if you use PPE, it obviously needs to be worn properly. And the number of people I see with their mask on their head or around their ears or on their chin, and, you know, remembering to clean your hands, because that's probably one of the principal things that helps to protect both the patients and both yourself. So the PPE that's currently being used is principally to protect healthcare workers, but we also need to remember that we need to also protect patients from transmission of infections from us or from other patients. So I don't know if that answered your question, but it's kind of a broad question that requires, it's a nuanced approach in the end.
Yeah, I just hear from some of the other panelists and then come back, because there's I just want to dig into a little bit about, what the new implications are of mask use, particularly when it's relevant to visitors, patients, non-clinical staff. Right. But just move on to Kathy. I know, Kathy, you had a few slides in terms of what, the extra work on top of the measures that Healthshare has been doing in making sure that there's appropriate standards of PPE whilst new supply chains have opened up. So I'd love to hear from you, and then we have some questions for you too after that.
Thanks, Pale. I'm just hoping you can all hear me and can see my screen. So it's good to know that we're all actually quite consistent with our approaches. Okay, I can't actually. Okay, so this just really summarises nicely what Kate's gone through around engineering controls. So it's good to see that we're all talking the same thing. So those administrative controls and engineering controls, I know people particularly focus on negative pressure, but in fact the air handling systems in our operating suites are often much superior than the negative pressure, and so would, I guess, caution people running to changing engineering controls in those environments. But when we look at, what PPE is, and again, I think it just comes back from a clinical perspective, the things that, Amanda's also said, we look at the fact that PPE needs to be suitable for the nature of work, it needs to fit properly, it should be stored properly. If it is marked as reusable, then it needs to be reprocessed properly, otherwise it needs to be discarded. And most importantly, it needs to be used in accordance with manufacturer's instructions. And I think so gone are the days where, you would find your PPE on the shelf and just accept that, someone has provided it for you. I think as clinicians, we all need to really understand what PPE we're actually getting, understand the labelling, understanding the different levels so that we can make sure that we're putting the right things on. So PPE is applied for standard and transmission-based precautions, and so we should have a good understanding of that. So just really quickly looking at what that might look like. So if we look at standard precautions, it's you apply PPE based on the assumption or anticipation of exposure to blood or body substances. And so some of also the theatre PPE has been not only around patient protection, but to a certain level of protection of the surgeon and those around as well. So then if we go into the transmission-based precautions, so contact precautions, and if you look at each of the precautions, there is a layer of PPE applied based on that modality of spread. And then we have the situation like COVID where you need to combine some of those, and sometimes that's where the challenge and the complexities come. So contact precautions, so close contact, you put on an apron or a pair of gloves. Hand hygiene, obviously still very important. And it's really around the anticipation of the amount of contact as to whether or not you risk assess for an apron or a gown. And then for droplet precautions specifically is the mask and the protective eyewear, and then you can use that using either a shield. And historically, the surgical mask, now we can get into issues around level 1, 2 and 3, but historically the surgical masks would provide you protection against droplet, splashes and droplet organisms. Then for PPE, for airborne precaution, it's specifically the P2 and N95 as the component for airborne specifically. But again, for COVID, it's a combination of contact and droplet, or contact, droplet and airborne for aerosol generating procedures. It's important, so I know that Terry's mentioned fit testing, and there's a lot of debate, around how that should look. Obviously we are focusing on the necessity for fit checking, and also writing respiratory program around how we can better align fit testing in the system for our clinicians as well. So then you kind of end up with a risk assessment matrix around how to decide when and what PPE you need to apply based on what you're actually about to sort of undertake. The surgical masks, so it's important that you put those on. It's important that they fit properly, and that is also part of the review process that HealthShare is doing. So whilst we have items that are TGA registered or listed, because we are using many vendors and manufacturers that we wouldn't normally use, there is quite a robust system where we actually assess individually all the things that come to us. I guess some of the discrepancies sometimes is that the samples that are given to us don't always match the product that reaches the, the clinical floor, and sometimes we need to circle back and look at some of those things. And for P2N95 masks, for airborne precautions, regardless of whether you're fit tested, you must fit check to ensure that you've got, an appropriate seal every time you put a respirator on. And it's important to understand that the different types and shapes of respirators may require slightly different process to fit checking. It is important to understanding the difference between fit testing versus fit checking, and making sure that you fit check each of those. And that just explains, so you can see that there are a few different areas to do that. Eye protection, particularly for droplet precautions, is also very important, and we're seeing that increasingly so, particularly in Melbourne, and looking at either protective eyewear, goggles or shields, understanding that in some of the work that the surgeons particularly do, because you have other parts that you actually use for surgery itself, then some of these processes are probably a little bit challenging and something that we need to explore later. This is around just looking at what then it looks like when you're sort of doing contact and droplet precautions for COVID or someone who's got an acute respiratory infection. There's a couple of different ways to move, and it's important that you remove in the most easiest way, that you don't contaminate yourself. So, and the second way is really to acknowledge that surgeons and the surgical environment are probably used to removing gowns and gloves as a single unit. So that's why there's a couple of options for that. There's a lot of additional information on the CEC website. There's various other sites and that as well, but we do have a lot of education and resources around PPE, donning, doffing, fit checking, some videos which are very useful and quick as well. Thanks, Pal. I'm happy to leave it there.
Thanks, Kathy. I'm just going to get in Melissa here right now. Melissa, it's represents ASONS, and just throughout at least the first peak, and I'm sure now has been navigating lots of questions for ENT surgeons who are one of the higher risk specialties in terms of exposure. So, Melissa, I was just wondering if you can share with us your experiences, and then we can sort of get the end user experience and questions as well.
Sure, thanks, Cloud. I guess in terms of looking at what ASONS went through, as a national membership body for ENT and surgeons who procedures put them in a high risk category due to COVID, our focus has been at both a national and at state levels. Back on March 7th, ASONS made the decision to convert our ASM that was to be held as a face-to-face meeting from the Friday 13th of March to a virtual conference to protect members and in turn their patients. From Monday 16th of March, we commenced PPE communications and investigations. We held a federal executive meeting, formed a COVID-19 working group, and then this group has met numerous times since. Our members were surveyed to confirm PPE needs. We also then commenced communications through emails and phone calls through to federal and state ministers for health, the New South Wales Premier's Office, PHNs, LHNs. Of those communications, somewhat frustratingly, we received limited responses. Those responses also took time to be received. In April, a month after emailing Greg Hunt's office, I received a letter from the Assistant Secretary of the National Incident Response Division advising that there was a worldwide shortage of PPE due to the pandemic. Also in Australia, this was exacerbated by the drawing down of masks to help respond to the bushfires, that the distribution from the stockpile in accordance with health priority, and the letter stated clearly that the department was not going to directly supply our members as ENT head and neck surgeons with PPE, and that it was only surgeons undertaking urgent surgery would be provided PPE by hospitals. In March, I did receive a phone call from the Director of Health Emergency Countermeasures Section in the Office of Health Protection in the Department of Health. It's a mammoth title. She provided contact details of 2 government suppliers. Now, I contacted both on behalf of members. One was a medical company able to supply, but only within quantities within the hundreds of thousands per order. The other was a wholesaler. Again, they were able to supply, but again in the hundreds of thousands, although they were willing to look at slightly smaller quantities. This particular wholesaler also advised that they changed from being a distribution company to coordinating acquisitions only. They advised that they'd changed their terms and conditions to payment at 100% upfront, and that the purchaser was to assume the cost of any flight risk if the goods purchased did not arrive. These terms and conditions, interestingly, were the same that were provided to government. Obviously, neither of these were options for ASONS members in terms of ASONS members purchasing. I then went on as a result of that to contact numerous well-known suppliers, and I was advised on numerous occasions that each supplier was not taking on new clients. Some said their supplies were based on 2019 sales with a small increase in quantity for 2020. And then due to limited supply, in some cases they were using a global desk to actually manage supply for any new orders beyond their existing clientele. For some of them, that process then changed to selling to hospital only. We then, as a result of that, looked to suppliers who members could place smaller orders with and had terms and conditions that supported refunds. We were trying to minimise the risk from a purchase perspective for members. Once we'd found these companies, we assisted members in creating buying groups to be able to manage the quantities that were expected to be ordered. Members then experienced issues as a result of supply. Delivery times were delayed from an approximate 10-day delivery to months or more. Cancellations of passenger flights into Australia limited freight capacity and increased the cost of freight significantly. COVID impacted on countries of manufacture. There were delays out of China at a customs level. We also found with some companies that when freight was put on flights out of China, it was taken off the planes in other countries and did not arrive. We continued throughout all of this to look for other suppliers, and during the time found many suppliers in the same situation. We also found, for example, 3M masks being sold on Kogan. We advised 3M, who took the information to their legal team. Throughout supply continued to be a huge issue. Our members also had concerns within hospital environments where members had, for example, sourced their own PAPR, being told they couldn't wear it. There were inconsistencies across hospitals and across states. We were also made aware of inconsistencies across states to do with fit testing and also with support. I guess now, over those ensuing months from when we first started back in March, supply concerns have moved over time to concerns over quality. Though now more recently, I guess there are some concerns over supply again increasing, especially due to what's happening in Victoria. And I guess in terms of the COVID working group, the groups continue to be communicating with the Office of the Chief Medical Officer regularly, and they continue to do so. There's more, but in terms of a snapshot of what we've experienced, I think that that covers it.
Thank you so much, Melissa. I think, it's just great to see the stream of things, and it's also, I think, as a state, we're probably better placed now to handle, I suppose, the next wave, if that comes, compared to what we were in March. I really like to bring in Arthur at this point. I know that he's managed to log on, and welcome him firstly again. Arthur's had been doing a tremendous amount of work as the chair of the Surgical COPS in terms of setting up guidelines, and we've been meeting on numerous after our meetings to do this. And I suppose I'd love to hear from him a snapshot of the challenges that he's had, how we are faring in New South Wales, and also further work to do in this area in terms of navigating the upcoming challenges that we face in PPEs.
Yeah, thanks very much for asking me, Payal. I would just start by saying this has been a journey for me. I can remember being visiting professor in Alabama in February, planning out my very organised 2020, and like all of you on the line now, that completely blew up, and I've disappeared into a world of PPE that I knew nothing about beforehand, and all sorts of other things. But we've all had that experience, and it's been quite a year. I would just say that there were issues in the way we responded at the very start, I think, and there are lots of things that we'll all need to take away in terms of coordination, how we respond to these things. My experience was that it was initially assumed that surgery had nothing really much to offer or to be involved in how we were going to react to the COVID pandemic. But of course, urgent surgery doesn't stop. There were a lot of issues that were not really appreciated before surgery got involved, and that all happened very quickly, actually. And I think the day that I was asked to run the COPS, the first thing I said was that, and I never thought that I'd be in a position like this, the first thing I said is that we need to stop all elective surgery right now. And somebody needs to announce that this afternoon. And that was a very unusual situation for me to be in, I have to say, but that's how it started. So I suppose that because this was new to all of us, it's fair to say that we really were starting from a not a great position, I have to say. I'd be the first to admit that. But I think that very quickly, and I would say that the thing that I've been most struck by was the amazing input that we've had from everyone that's been asked. And that's been a remarkable experience for me, I have to say. So within a very short time, the surgical COPS was set up, which involves basically infectious disease input, nursing input, clinical director of surgery input, all of the people that you need to have. And I must say, naively, I thought at the start that organising guidelines for PPE would be relatively straightforward. And it just shows you how sometimes, no matter how old you get, you still remain naive. And in fact, it's been one of the most difficult things. And part of the problem was because of our lack of coordination, within a week, there were multiple guidelines from multiple bodies, many of which were conflicting, many of which were difficult. And I have to say that, at the end of the day, it took a long time to work through a lot of that. The current guidelines are really an amalgamation of, as I say, input from many people. My contribution has been quite small, I would add. And it's the best we have at the moment, I think. And it's a combination of what CEC brought, ACI, Ministry, and all of the professional groups. And I think that's been very helpful to get all of that involved. In terms of where I see all this going, and I think that's probably the most important thing, I said to anyone that would listen to me, I said, well, 2020 is a wipeout. We're not going to get anything else done of great importance. We had a huge agenda of things that we were going to do in 2020. Of course, that all has blown up. But increasingly, I'm concerned that that's going to apply to 2021 as well. I don't think this is going to be finished by the end of the year. I think we're going to be dragging on much longer than we thought. And I think we all need to be prepared for that. And I do think the most important thing is the flexibility that we'll all require, because things will change. There is no two ways about it. I think that we need to understand that if there is a second wave in New South Wales or a third wave, and some people would argue we haven't really had our first wave yet. You know, Kate will answer that better than I. But I think that we will need to be very flexible. And I know at the start of all this, we thought we would stop elective surgery, we'd restart it, and that would be the end of it. I don't think it's going to be as simple as that. I hope that I'm wrong. But I think that we're going to have a much more complicated course before this is over. I think we may well see area-specific implementation of guidelines. We're already seeing that in Australia. If you live in South Australia, that's not really going to be an issue in that state. Victoria, perhaps surprisingly to all of us, has obviously become the most affected state in the country. And we are at risk of being the most affected state as well. As we discuss virtually every week, I think we're very encouraged by the numbers and by the modelling. I have to tell you that when I first saw all of the modelling, I was absolutely horrified about what could happen. And I really thought that this was, you know, going to be something really awful to face in Australia. And then if you asked me a month ago, I'd become a little complacent and said, no, it's going to be all right. And now I'm back to anxious. So it goes up and down. And I think we're all like that because everything changes so quickly and we have to be prepared for that. As I said at the very start of the pandemic, surgery had a very important role. Surgery's role was to look after critically ill surgical patients, preserve PPE for the people that needed it, and keep out of the way of the workers who were mainly going to have to deal with COVID. That was going to be our role. That's changed a lot because there are clearly going to be, there's a great risk that there will be a number of COVID-affected patients who require surgery. That has all sorts of implications, which I won't bore you with all at the moment. But as I say, I think we're going to need to be flexible. And unfortunately, I think the journey has a lot further to go. We will need to be constantly reassessing what we do and constantly listening to each other. I think that's one of the most important things that we can all learn from this. The one encouraging thing that I have taken out of this is that I think the performance of government, both federally and state level, has been truly remarkable. Now, those of you who know me will never have heard me say that before, but I think it's been truly remarkable, and I think we should all be proud, actually. And I think the performance of New South Wales Health to pull together a very difficult situation has been really quite awe-inspiring for me, but we're going to need to keep doing that. And what it does show in a positive sense is that when we all get organised and we pull our resources together, we have a remarkable ability to deal with very difficult situations. And things that we thought that we couldn't deal with all of a sudden become quite simple. And I suppose that I just tell one little funny story at the end of all of this. In about November last year, we had what we thought was a very visionary idea at Westmead. And I'm almost embarrassed to tell you now, but we thought that we would start using telephone consultations for people in outpatients instead of seeing them as outpatients. And we thought that was quite visionary in November. When you look at it now, where we can have 75 people on a Zoom conference, the other funny thing I should say is, though, that when we submitted that to ethics, they knocked it back. So it's remarkable how things can change in a very short period, and we can actually move forward much more quickly than we ever thought we could. So,
sorry, Tina, I just have as you've touched on already, that you know, as we've come out of the first wave, and you know, we're heading into not really sure what is coming, we are constantly drawn and torn between managing two health crises. One is the crisis of the pandemic, as one is also the crisis of complications of delayed care. We want to minimise both of them. In the setting of the new guidelines, and we know that whilst we've been setting these guidelines, elective surgery provision has been intimately tied with PPE availability. And whilst we're doing well now, I suppose the question I have for you and the panel as well is that the concern that we don't, we want to use PPE responsibly, whilst we've increased the use of PPE, but we also want to make sure we use them with good standards. And we're suddenly also needing to increase literacy of PPE use quality and potentially even reusable PPEs amongst allied health professionals, non-clinical practitioners, mainly visitors as well as patients. So I was just wondering what your advice would be to our colleagues online in practical things that they can take. And maybe once we finish with you, we can go to Amanda with respect to, again, regulation, and Kate and Kathy to get their opinion.
I think that I'm very concerned still about the potential that we can burn through PPE very quickly. At Westmead, we introduced masks just for one weekend with patients and doctors. Last weekend, we burned through 10,000 masks almost in a blink of an eyelid. Now, you know, that's, if we were to find that our numbers increased, our burn rate will go up enormously. We have a very good predictive tool, which we're trialling at Westmead at the moment, which will roll out across the state to predict how much PPE you're going to need. And I think that will be very important. We have to look at reusable PPE. And I think one of the things that I've said from the very start, you have to minimise, absolutely minimise the people that are in hospitals. We have to, unfortunately, limit visitors. I said at the very start of this, we needed to suspend medical student teaching. Not everyone agreed with me, but that was because I didn't think we should put them at risk. And I didn't think that we could provide them with PPE the way the circumstances were at that time. And I think those things are still on the table if things deteriorate and need to be considered. In terms of elective surgery, it is a balancing act. I feel very strongly that we have to pick the eyes out of people that are waiting, and the waiting list, so to speak, to make sure that we get through people who are at risk of deterioration in their state or of harm. We're already, I'm basically a clinician still, and I must say I'm very concerned about the way we've seen a drop-off in cancer presentations. And interestingly for me, that really went up again the last 2 weeks. But every one of those people has advanced disease. Every one of them has had symptoms for 6 months, and some of them are very young, and they're going to do very badly. And I'm concerned that we have a big pool of people in the community who are not coming forward because they feel they can't. And I frankly don't know what we can do about that. It's very disturbing. But what I am sure of is that as the pandemic is controlled, which it will be, I don't know exactly when that will be, we're going to see a big uptick in demand for surgery of all types, and that's going to be very difficult to deal with. And as you know, Payal, we'd started planning for working through some of that just 2 weeks ago, and that looks premature now. But of course, one has to just be flexible and readjust to the changing circumstances.
Absolutely. I just wanted to ask Amanda, just in terms of clarification, based on what Arthur's just touched on, I know that a lot of the hospitals are trying to strategize how they use up their PPEs. And we've talked about risk mitigation. So, you know, when we're using it for visitors to the hospital or non-clinical staff, the potential to have reusable PPEs or cloth masks. Now, sometimes we find that in hospitals, patients are turning up even though they've been called, or visitors are turning up with the patients without any masks or without any face protection. And in the setting of that, if the hospital gives out, you know, or donates masks to the patients, and I suppose the patient then through that interaction in the hospital or later on, or use of that mask does contract COVID, what is the hospital's responsibility, or should we really be making sure that when they do that, they are really spelling it out that this is, you know, this is not, I mean, how much information do we give to those users about the type of face protections they're using?
I think the difficulty there is that you can only control so much, for example. And so what we tend to say in terms of the TGA, we don't legislate release of masks. We don't legislate the supply of any of the PPE. That's the National Stockpile. That's the Office of the Chief Medical Officer. So I can't really speak for them at all. But what we tend to say is if someone is a consumer of a product like a face mask, they need to be familiarising themselves with the differences in the mask that they're using. They need to be familiarising themselves with what the use of that device actually is, what that mask actually is. Back in April, we had several conversations with the FDA and the MHRA and Health Canada and a few of the other international regulators about the potential for a very limited supply globally of PPE and what sort of recommendations we could provide to all of the, you know, interested sort of organisations and stakeholders, and talking about whether or not, you know, what were the protocols in terms of whether or not you have to reuse PPE. And so we have 3 categories of sort of standard conventional supply, contingency supply and crisis supply. And in terms of what we recommend in terms of how to reuse devices. But that is, you know, this, as Arthur said, this is an unprecedented situation. And so we're all continuing to sort of learn and evolve what we're doing. But the only thing I would say is that if you're giving the patient a mask for their, or a family member a mask for their use, then it has to be the right mask for them. So it has to be the right type of mask. And that goes back to, you know, like what Kathy was saying in terms of the appropriate PPE for the particular situation that someone's in. But we don't have any remit over how much people get or what they get, because that is based on the sort of the coordination of the response coming back to the federal government. But I would say that in the end, the consumer has to be aware of what they're using. If you are supplying it though, it depends a little bit on if you're a supplier as a sponsor, so you have brought the device in and are supplying it and selling it. So that is a different situation to when you are just supplying it to someone in terms of just for their own personal use. So it's a little bit tricky. The legislation is extremely intricate. And again, I think it would also depend a little bit on the hospitals and the state jurisdictions, their own guidelines and protocols as well.
Sorry to ask you a difficult question. Kathy, do you have any guidelines, any advice for hospitals in terms of what level masks, you know, do they use reusable masks for certain scenarios, or whether they use strategized level 1, level 2, level 3 masks in certain situations?
Yeah, sure. Thanks, Pal. So how we've written the guidelines currently, particularly with the change in the Amber Alert, is that, you know, if you have a patient turn up and they've got an existing cloth mask on and it looks reasonable, then we're not saying to change it. A lot of the messaging out there from New South Wales Government and nationally is really around mask wearing, if you choose to do it where you can't social distance, provides a barrier. So we are trying to kind of call a different level mask a public barrier mask. We have a lot of stock that may perform in a similar way as many of our other level masks, but we can't validate, for example, with certain paperwork. So they're still useful in the system as, for example, a public barrier mask. You know, normally we would have had the luxury of maybe not providing level 1 surgical masks to the healthcare system, whereas they do have a role. And so we've put out guidelines around where you could essentially use those. We're using those for home sort of patient kits. You know, so we definitely have some guidelines around those. And what we're really trying to do is inform the system so that we can reserve your level 3, you know, surgical masks for surgery, you know, your level 3 and 4 protective gowns for surgery, where they're really necessary, and align the system with other PPE based on fit for purpose and guides, and trying to give them information around that.
Fantastic. And any on the horizon, any hope for increased local manufacturing of these products while we're still international supply is still going to be under stretch?
Yeah, there's certainly, I mean, Amanda may have some additional information. I mean, there's certainly a lot of things, you know, looking at that. You know, I'm just not sure how then it's addressed in terms of certification, validation, and meeting the various standards, given the standards are predominantly based overseas as well.
Amanda?
Yeah, so there is actually a vast increase in the amount of Australian companies willing to change their protocols and start, you know, producing PPE, and indeed actually ventilators and point of care testings as well. And I guess this comes down to a little bit about what it's about. You know, when someone actually wants to manufacture or supply a device, there is a significant number of standards, depending on what the device is, that they need to adhere to. Now, that doesn't mean that the device can't be made. It's just about making sure they've got access to that documentation and understanding what that means. And one of the sections in the TGA is the auditing section, and we generally usually have auditors going and looking at manufacturing sites constantly here and overseas. So that's one of the reasons, I guess, why having TGA certification is actually, for medicals, is actually important, because that gives you that level of safety, because what that's meant is that manufacturer has had to go and look at those standards, those quality standards. So, and that means it's all about quality control. And so that means they've had to look at safety standards for chemicals or biological stuff. They've had to look at performance. They've had to look at engineering, manufacturing, whatever it is that their device needs and is entailed. So, for example, for face masks, there are 9 different types of standardized you know, protocols that people who want to produce masks have to look at and actually adhere to, along with the TGA's requirements in terms of essential principles. So you're getting a risk classification of a device, and you're getting a quality control process. So you're actually making sure that the device that's there in front of you has gone and met those requirements. And then on top of that, once something is on the ARTG, then it is continued, it's monitored. So whilst it's on the ARTG, it's subject to ongoing regulatory control. So if something goes wrong, then, you know, it's discovered and things can be done about that to fix that. So certainly, whilst there is international protocols and standards that we look at, local manufacturers can still look at those and still adhere to those. And, you know, the Standards Australia is also an excellent resource as well. So It just depends a little bit on the device as to which standards that are required to be reviewed. But certainly we've had a huge increase in local manufacturers, and I think it's a fantastic tipping point for Australia to know that they can manufacture their own goods. So
it's fantastic. And then do you have some advice, just coming back off on some of the issues that I suppose Melissa touched on, do you have some advice for the clinicians, I suppose, in the community, so in outpatients, in rooms, in terms of how they can make sure that they follow those standards, as those standards, as you indicate, may change, and, you know, for example, you might withdraw approval of a product if it's substandard?
Yeah. So, you know, I think we found this in general practice as well, similar to sort of what the ENT guys found, is that, you know, there was just absolutely nothing. There was just not nearly enough for general practitioners, who were, in fact, the front face of people initially when we first started seeing cases. People were coming in and there was not nearly enough PPE. And so realistically, what needs to happen when you want to be sure that you're protecting yourself in whatever device it is that you're using, there are things you need to look at. So clinicians, if they want to look at what they're making sure that what they're using is appropriate, you look at the technical information that comes with the product. You look at the instructions for use, and you make sure that the supplier and the information that you need to see is in with the package, because if it's not, then, you know, that's a risk. You can always check and see if your face mask or if the PPE that you're looking at using is actually ARTG registered. You can look it up on the website. You can, there's a summary of information from Standards Australia, which is really helpful as well. And that's on the sort of standards and conformance of PPE. So that's really helpful. And so you look at what the device is intended for, and you make sure that you're using the device in the same way. And if you have any worries about your device, so for example, you know, we have had a few issues with some devices that have not met the requirements, even though they've said they've had, you can contact the TGA and get them to check it out.